Welcome everyone to the Hands-On Telehealth Interview Show. I'm Nirav Desai, and I'm very pleased to welcome as my guest today Debbie Voiles. Debbie is the Director for Telemedicine at the Texas Tech University Health Sciences Center. During her time here, Texas Tech Telemedicine has added 10 community-based sites to its network and grown consults by over 380%. Today, Debbie is here to share with us her insights on how they've grown their telemedicine program. So Debbie, I'm really thrilled to have you here. Thank you for being here.
Thank you for the opportunity to talk today.
Oh, thank you. Thanks so much. All right, so Debbie, one of the first things I love to ask people when we first get started is, what do you like to do outside of work?
Well, up until recently, it was chase my kids. But they're all,
Yeah.
yeah, they were all active in sports and everything up throughout high school and everything. But I've got two of them fixing to be in college, and so our downtime is changing, and now I'm going to start enjoying some me time. So,
Oh, cool. Very good.
trying to do a little bit of traveling and getting to see places that I want to see as opposed to where competitions are held at.
Oh, yeah. So primarily domestic, or are you planning on going outside of the country too?
Now, we're going to start domestic to begin with. There's enough places in the U.S. that we haven't been able to see that I want to see. So that's kind of what we're going to start with.
Very beautiful. It's good. There's so much to see in the U.S. It's amazing. So
Yes.
very diverse, actually. So okay, so tell us how you got started with telemedicine. I know you started a while back, so it'd be great to kind of get.
Yeah, actually, to start back what got me into it, I was going to graduate school. I had been in the oil and gas industry for a long time, and the company I was working for went out, sold out, and moved, and so I lost my job and thought, okay, what am I going to do? So I went back to graduate school, thought I was going to do finance, and decided that wasn't really what I wanted to do. And there was a program at Texas Tech for health organization management. And I thought, one of the things that's always going to be around is healthcare in some form or fashion. So I got involved in that program through while I was getting my master's. And one of the things I had to do was an internship.
Uh-huh.
And one of the offerings was telemedicine. Didn't know anything about it at the time. Did an internship. Just fell in love with what the concept that you could do with technology. They offered me a job at the end of my fellowship while I was finishing up graduate school, and I've been here ever since.
No kidding. Very cool. That's good. And so then when you started right after graduate school with that, then what did you, was it very familiar to you at that point since you'd already done your internship, or was it a real big challenge taking on the new role that you had?
I started out as the clinic coordinator, working with all of the docs and scheduling clinics and the patients. And at that time, we had we had 2 community sites and 15 correctional sites that we had going. And so the majority of the focus at that time was on correctional telemedicine, which is a great thing. Being able to provide services to the units and keeping the inmates where they need to be as opposed to out on the road traveling. So
Right.
there's a great benefit to the correctional. But in West Texas, we have 108 counties in our service territory, and there's a lot of open areas and people were not getting access to care. And so that was one of the things that I, started working on, is trying to figure out how we could expand out the community-based telemedicine. It was really slow coming because reimbursement was not very good in the early 2000s, and it's still it's still not where it needs to be, but it's a whole lot better.
And was that enough then? I mean, so reimbursement was not great, but you were still able to get people to support the telemedicine effort.
Yes, and we have really worked hard in Texas
Uh-huh.
to get Medicaid on board to reimburse for telemedicine, which we were one of the first states that Medicaid actually would do that. We also worked to get our insurance board to make it a requirement that anything billable face-to-face is billable through telemedicine. So, it's been a slow struggle, but it's going to be worth it in the long run.
Yeah, that's great. But then, so you were still able to grow the program, though, right? I mean, you got
Yes.
people to sign up and
Yes,
do it,
we did.
right?
And a lot of it was based on, we got a couple of different grants, which, as far as buying equipment and getting started, that's about the best economical way to be able to do that. And we've learned from that some communities can sustain the program and some are not able to. And so we've had a lot of good experience learning what works and what doesn't work.
Oh, that's interesting. So, and can you get into that a little bit? I mean, what, in terms of what works and what doesn't work with respect to grant funding and
Right.
things like that?
Yeah.
Yeah.
Having the grant funding to pay for the equipment is really good because, the equipment that we're using here at the Health Sciences Center that we ask the communities use, is really, we want everything is live interactive. We don't do any store and forward because it's not reimbursable in the state of Texas. And so when we look at a community, we have learned that you've got to go in and do a community assessment, talk to all of the leaders in the entire county and the community, county judges, the mayors, the superintendents of the schools, everybody in the community, because that's who's going to have to support it to keep it going after the funding for the grants runs out. And so, you've got to have buy-in from everybody that would use the equipment. Is one thing that we have learned for it to be sustainable. If a clinic wants it and they haven't convinced the community that it's a needed service or it's a benefit to them, it's not going to be a profitable, sustainable program in the long run.
So you're saying that the funding comes from the specific community that the telemedicine support services are going to be provided to. So it could be, if you're doing it for a town, then the mayor and some of the other politicians and other, people within the community have to help support it and then provide for the funding. Is that
Well,
right?
yes.
Or,
I mean, because ultimately, you're going to come and you're going to run across programs and communities that want to do telemedicine that there's not grant funding to be able to do this. But it would be a benefit to the community to keep the patients there locally as opposed to on the road traveling.
Right.
And so you've got to have buy-in from everyone to use the equipment so that the clinic can get reimbursed for providing services and having it. In Texas, through our Medicaid program, they can get reimbursed for a facility fee just like they do for Medicare. And so where it's not a lot, at least it's a little bit to help sustain the program, pay for the connectivity, and pay for the leasing of equipment and things like that.
Interesting. Okay. All right. So then what do you have to convince the people of when you're talking to them to say, hey, this is worthwhile. Let's do this for your community. What can you talk about the specific words or messages that you have to get over to them to convince them and bring them on board?
Well, a lot of it is, having them see what the financial benefit is. When you can keep a child in school and only have to be out of school for an hour for an appointment, just like they would if they lived in an urban setting, it's, they're in school, it helps the school, it helps the students. Parents are not having to take off work. If they're in most of these small communities that we go into, the parents are hourly paid employees, and most of them don't have leave time. So if they have to be away from work, they're not going to get paid. On top of that, if they have to travel, now they've got the travel expense to go along with not getting paid from their job to be able to take a family member or themselves to see a physician in another community.
Yeah. So then, go ahead.
So once they understand what the financial savings to them is, it's huge.
Right.
To the community in itself, the services are being rendered there. So if any lab work needs to be done, any kind of prescriptions need to be filled, all of that's going to be done locally now, as opposed to that money being spent in another community.
Right. Okay. And that is what helps convince the politicians and everybody else to,
Yes,
yeah, keep it all local as much as possible.
exactly.
Right. Okay. Very cool. Okay, great. And then, so let's talk about, since you grew this whole program, right? What do you, looking back now, what do you think are some of the biggest successes you've had? Maybe your top three.
Well, obviously, expanding the number of community sites that we have. I mean, that's where we're having a big impact um, on being able to provide those services to a lot of communities. As I mentioned before, in West Texas, our service territory is about 108 counties. It's about 49% of the landmass of Texas. Runs
How much?
8 hours.
Oh, what did you say?
8 hours. Yeah.
39%?
Oh,
Oh, 39%?
no, 49% of the landmass.
Wow.
But we only have 12% of the population. So we have patients in some areas that are having to travel 90 miles one way for primary care because there are no physicians in their communities.
Wow.
There's 22 counties in Texas that don't have a physician practicing in them, and there's 12 that don't have a physician, nurse practitioner, or a PA. And so this is, telemedicine can have a big impact on what we can do to provide healthcare services to these people
Mm-hmm.
without putting an undue burden on themselves or the system to pay for travel costs to travel into the urban settings to be able to
Right.
be seen. And it's not just a rural thing. We've got in El Paso, a city of 750,000. There are 7 dermatologists, and not one of them will take a Medicaid patient. And so the closest Medicaid dermatology providers are in Lubbock. And so for those Medicaid patients, they have to travel 6 hours. It's about 350 miles one way from El Paso to Lubbock
Oh,
to be seen. And if it's something that is just, a rash or something like that, that's not a life-threatening thing, I mean, that's a long ways to have to travel to see a doctor. And so where in Texas, reimbursement was focused on the rural setting, we have really worked with the Medicaid providers in El Paso to get them to waive that for pediatric patients. And so now every Thursday afternoon we have a dermatology clinic and see pediatric patients from El Paso. The cost savings to the system is anywhere from $500 to about $1,200, whether the patients drive or they fly. So it's huge, and those are the success stories that we like to talk about. Being able to save not only the patient's time but the system money in the long run.
yeah, that's very cool. So, and then do you feel like based on everything you've gotten to accomplish that you've gotten that return on investment from, everything you guys have put into it and the money that's brought in and everything, or?
It's not so much in our philosophy. It's not so much about return on investment, but about taking care of patients. Being part of a medical school, one of our missions through the medical school is to provide healthcare services to patients, whether they can afford it or not. And telemedicine just allows us that opportunity to expand out to regions that we wouldn't otherwise be able to reach those patients to provide those services.
Yeah, yeah, and it's that's absolutely terrific, right? Because it's so important to get that out there for everyone. And then, was there ever any kind of concern? I mean, I think that's great because it's a lot of academic medical centers do that kind of take that kind of approach. There are some, of course, that are still looking for that kind of economic approach. What would you say to them if they're any advice from your standpoint? Maybe why they should or shouldn't consider that.
Well, one of the things that we've looked at and we've studied is seeing a telemedicine patient is actually cheaper for the physician and his staff than it is face-to-face, because everything is done on the patient side as far as checking the patient in, doing the vitals. You're not tying up one of your consult room or clinic rooms, and so you're not using your supply. So in the long run, seeing a telemedicine patient from a physician's perspective is actually cheaper than it is to see one face-to-face.
Yeah.
And so, you get some economies of scale, the more patients that you see. As far as that goes, you're not tying up your clinic time. And so there's some cost savings there that kind of offset, what it is that we're trying to get them to do. They're getting paid exactly the same as if a patient walked in the front door. So, that's one of the things that we really work to try to educate our physicians here is, if you see a telemedicine patient, you're going to see this patient anyway, whether it's a face-to-face or a telemedicine. If you see them through telemedicine, you're actually going to be making a little bit more money because it's not costing you much on the clinic cost.
Oh, interesting. Wait, it's not costing them much on the what?
On the clinic side, in their own clinic.
So, because they don't have to use other staff to try to bring the patient in, admit them, do all those kinds of things.
Exactly.
Interesting. Oh, okay. And so they buy into that pretty easily with
some
that?
of them do. It's a challenge. I
Yeah.
mean, getting provider buy-in is probably the biggest challenge that we have. Some of them get it. Some of them just don't. Still, we're still struggling. We're really trying to work with the younger doctors as they go through medical school and do their residency to educate them on the benefits of telemedicine, not only for themselves but for their patients. And so we're hoping that as we work with the younger group that are so used to computer-based technology and playing video games and doing everything, electronically, that will broaden the amount of providers that we have to offer services for.
Right. So, and then what about you mentioned that, some are more receptive to it than others. Do you find within a specific set of clinical disciplines that it's more amenable versus others?
Yes. Ones that really have issues with wanting to have the hands-on experience that they can't do. If they do a lot of testing when a patient comes in, those are ones that we really have a challenge to try to get them to see the benefits of telemedicine. One of the areas that we struggle with is our pediatric neurologist, getting them, because they do such intense testing when a patient comes in that we can't replicate that, or we haven't figured out how to replicate some of that through the technology. So trying to get them, to buy into doing this, it has been a challenge.
Gotcha.
But we've got an adult neurologist that is doing this, and so we're hoping that through his experience that we can take that and work with our pediatric neurologist and show them that there are ways to be able to do this. Not every patient can be seen over telemedicine, obviously, and we recognize that. But if we can save, even 7 out of 10 patients from having to travel for some type of service, then it is a benefit in the long run.
Right. Because I guess I think of trying to sell telemedicine sometimes as, what is the other alternative if you don't do that, right? I mean, if that patient if you can't see that patient at all, versus if you can see them and do some things, isn't that better than being able to do nothing for them?
Oh, exactly. And that's one of the things that we try to work with them and tell them, if we don't see them over telemedicine, they're not going to be seen until they end up to the point where they're in the emergency room. And now, we've disadvantaged the patient because their health condition has deteriorated, but we've also added an undue burden on the system because it's gotten to the point where they've ended up having to go to the emergency room and be treated for a more expensive procedure that maybe could have overcome if we saw them sooner.
Yeah, and I imagine the argument from the physician standpoint is something like, well, if I can see them but not really be able to do the appropriate workup that I'm typically used to doing, then I might not be able to provide the appropriate diagnosis, and then I could make an error or whatever, that sets me up for liability.
Well, and a lot of times what we try to do in those cases is say, okay, fine, we understand, bring them in initially, do all your testing, but allow that patient to have all their follow-ups done telemedicine.
Yeah.
And for most cases, follow-ups are just reviewing labs, reviewing testing results, things like that. And so you're not going to have the need the hands-on for those kind of things, since it's just talking heads. And so working with them, trying to get them to understand that and agree to at least start with follow-ups has helped us a lot to get physician buy-in.
That's a great idea. Yeah, that's cool. And then what about, do you use mid-levels and other folks instead of physicians as well for any?
Right now, we don't. As far as what we're providing is all physician-based.
Uh-huh.
Up until recently, and it's still in the process of being approved at the Medicaid level here with HHSC, is being able to bill for a mid-level seeing a patient over telemedicine, because up until very recently, our medical board has dictated that it has to be a physician seeing the patient, and so we've tried to, follow those rules. They have since we've been working with them to try to get them to understand that there are other providers besides physicians that could see patients and provide a great benefit through telemedicine. And now we're just trying to get the reimbursement to go along with what those rule changes are.
Right, right. And so right now, is everyone you're covering, are they all Medicaid?
No, we see Medicaid, Medicare, private insurance, self-pay. If it's a self-pay patient, we find out from the provider what the cost will be. We let the patient know up front what the service is going to cost, which would be the same if they drove in and saw them face to face. So the savings to them is that they don't have to incur that travel cost, and so it's a big benefit even for self-pay patients.
Yeah. Okay. Very cool. And then what I didn't get to ask you this a bit earlier, but what clinical disciplines are you covering right now?
We are covering dermatology, endocrinology, pulmonology, urology, psychiatry, both adult and pediatric. We're doing some psychotherapy stuff. We've done some cardiology, neurology. We are just in the process of starting a new clinic in Abilene where we'll be seeing HIV patients. So we're adding infectious disease to our list. Genetics, and I think those are the big ones that we're doing right now.
That's interesting. So then, what was I thinking about that? So with all these different disciplines, are they all scheduled consults? None of them are like emergency on the spot consults.
We actually general pediatrics is the only one right now that we're doing on a non-scheduled basis. We've got a couple school-based health clinics, and if they come up and need a patient to be seen quickly, then we can get one of our general pediatric physicians to come in and see them. Most everything is scheduled. We have 2 different scheduling systems depending on what the specialty is. Some of the physicians, we have enough patients need built up that we have block schedules with them. So as an example, dermatology, we've got every Thursday afternoon between 1 and 3. And so however many patients we can get in that 2-hour block schedule, we get them seen. Psychiatry is another thing. We have blocks of time with our psychiatrists that we can schedule patients with. Some of the others that we don't have a need for on a regular basis, like pulmonology, we schedule that into a clinic rotation, just like they would a normal patient. They just happen to be going to be seen over telemedicine as opposed to a face-to-face.
Interesting. Okay, so then you do this, and then you have a whole in-house grown system,
Yes.
for doing all the scheduling and managing of all
Yes,
the positions.
I have 2 clinic coordinators. One of them really focuses on the correctional program, and one of them focuses on the community program. We're the central office, so we work with the communities and the physicians. All of the scheduling gets done out of our office. We're kind of the middleman. We've determined that that's the best way to make this work in West Texas. They have one central contact person to, whether it's the community side or the physician side, to work with, so they're not having to work with each individual specialty on the community side. So it's made it a little more efficient for us to be able to offer those services. And it also allows us to be able to see what's going on with the clinics. I have the coordinator set in on the clinics to make sure that we're providing the quality service that we need. The connectivity is where it needs to be. The patient, they're there if the provider or the presenter on the patient side is having issues with equipment. They can troubleshoot that. They can direct them on how to run equipment. So that's kind of how we at Texas Tech are running the program.
Very cool. Good. Okay, now let's switch over a little bit into some of the key decisions you had to make as you grew your program. What can you talk about some of those? What were some of the biggest decisions that you had to make?
Well, one of the biggest decisions that we had to make was we were working on a grant project where we were originally supposed to build out 30 community sites for Medicaid enrolled children. After it was going to be a 3-year process, after the first year, the funding that was for the grant started getting cut. So we got knocked down to only doing 19 sites at that time. We'd, in a matter of 13 months, we'd built up 19 community sites for the project. And then as we moved forward, it just got to be financially, the funding source just kept shriveling up. They kept wanting more and more documentation. The focus from their level changed from what we'd originally agreed to. So basically, we ended up agreeing to split and go our separate ways. And so that was a really tough decision because, the concept of what we were trying to do was so important to be able to figure out how to get communities access to care. And so making the decision to sever ties with the grantor because of circumstances, that was a tough decision because, I had grand expectations about what we were going to be able to do, and we weren't going to be able to do that in the long run. So that was a tough decision to make.
And just to ask you, so then did you have to actually stop providing services to those?
At that point in time, we gave the communities that, through the grant, we were paying for several things. We were paying for the equipment, we were paying for the connectivity cost, and we were also providing salary support to people in those communities to do telemedicine. And so when the funding stopped, obviously that financial support stopped, and the clinics had to figure out how to take over and pay for those services themselves a lot sooner than we had originally planned on to begin with. We were looking at how we could eventually phase the money out so that they could figure out how to be sustainable. As I mentioned, we had done 19 sites. Unfortunately, only 9 of them decided to continue on because we did not have enough time to figure out how to do that sustainability plan for them. But, we learned a lot of lessons from that. The focus at the time through the grant source had been for Medicaid children. We learned that you can't just focus on one payer group and try to make something sustainable. In West Texas, as far as that goes, you may not have 10 pulmonology patients that need to be seen that are Medicaid patients throughout our whole 108 service territory. And so it's hard to say, they were trying to make us, sustainable for each one of the different specialties, and there just wasn't enough patient base for Medicaid patients to be able to do that. And so that's one of the things that we've learned, that you've got to be able to provide services for everybody, Medicare, Medicaid, private insurance, in a community and also open it up to multiple specialties to be able to sustain the program in the long run.
Oh, that's so interesting. And so I guess that makes me wonder how do you figure out which disciplines you want to go after? You know, that
You know,
and across all those payer groups too, knowing that there's going to be a
right.
demand.
One of the things when doing our community assessments, when we go in and talk to the clinics or um, whether it's an FQHC, a rural health clinic, a critical access hospital, whoever happens to be in those communities, finding out what type of patients that they have that they're having to refer out to for. And so based on what their needs are is kind of how we're really focusing on what we're providing to them. That goes along with as we build out new sites and we do these assessments, we look at what their needs are to determine what type of technology it is that they need to have as well. If all they're needing is mental health services, you don't need to put a $30,000, $40,000 card in there with stethoscopes and otoscopes and general exam cameras. All you need is a monitor and a camera. And so that's really, really important to be able to do that and go out and do those assessments to see what it is that they need, what services that they need. And that's kind of how we base what services we provide is based on what the communities need.
Okay. And you have to aggregate that up across all the different communities, right? So that
Yes.
you see that you actually have enough volume across all of them put together to make it worthwhile.
Exactly. And, with having multiple campuses, we've got 4 medical school campuses throughout West Texas, one in El Paso, one in Midland, Odessa, the one here in Lubbock, and the one in Amarillo. And we've actually equipped all of our campuses with telemedicine technology to a certain extent. The majority of the specialties that we have are here in Lubbock, but we do have some areas that they don't have certain specialties in their communities, and so we can offer services to those communities through the technology. Just as an example, like I said, in El Paso, in pediatrics, we've got equipment and we're doing our pediatric dermatology patients. So it doesn't matter whether they're a Texas Tech patient or they're a community patient, a doctor from another outside the facility, our pediatric department has allowed them to come in and be seen through the technology for dermatology clinics to try to save the patients and the system some money. So, we're really trying to figure out how we can even go outside of what our normal patient level is to provide services and open it up to anybody that needs it.
Right, so you can continue to get that increase in utilization
Exactly.
across the board, right? Okay. Any other big decisions that you want to touch on?
Obviously trying to figure out how to expand out your program and, how fast you want to expand out the program. It is a big decision because you want to make sure that you can provide the services that the communities that you expand out to are wanting. And so, those decisions are always tough because I'll go out and assess a community and just really try to figure out how to get them involved in telemedicine. And after doing assessments, the long-term sustainability, I just don't see it. And so I have to let the communities know that, as it stands right now, the way that you want this focused, it's not going to be sustainable. And so those are tough decisions too, because, you really want to be able to help everybody, but there comes a point where, the community is just too small to be able to have enough patient base to make it sustainable in the long run. And that's a tough decision to make in telecommunity.
Yeah, I can see that, right? And I can imagine they're pretty disappointed because they want to bring that care over to their
Exactly.
community, right?
But you have to make them realize that, unless the clinic itself can get support from, the county or the city or something like that, that clinic is just not going to be able to maintain, the connectivity charges and the lease agreement charges for equipment based on the patient load that they have. And so, it's, you put it back, and once again, this has got to be a community effort because of situations like that.
Mm-hmm. And since you know about what these charges are typically, do you have a ballpark that's generally applicable that you can tell a community that it's going to cost you roughly X hundreds of thousands or dollars a
Yes.
month?
Excuse me. Most of the communities that we go into, we can run DSL lines into the clinics. And so in West Texas, a DSL line that's capable of running equipment will run you anywhere from $100 to $200 a month, just depending on where they're located at. So, that's that ongoing cost, whether you see a patient or not, you're going to be responsible for that. And then for the equipment, if they buy equipment outright, it can cost you anywhere from $10,000 to $30,000, depending on what you want to be able to provide services for.
You're talking about like a telemedicine cart,
yes,
or the video conferencing unit, right? Primarily.
Right. And we do have some equipment that we have from those 19 sites. We got all the equipment back from the sites that didn't want to continue on, and so we've been able to lease equipment out to some communities to help them, so that they're not having to actually fork out $30,000 up front to pay for the technology. And so we've been blessed in that sense, and that's really helped us be able to expand out our program to more communities, is because we had equipment in-house that we could lease out to them.
Yeah, that's great. So how many communities do you have that you're serving overall now, plus the correctional centers?
Right now we've got 15 correctional units, and I've got 12 community-based sites, in addition to our 4 regional campuses that we do various programs with.
A big network.
Yeah, not big enough though. I mean, there's still areas that we need to figure out how to better access, and so that's one of the things that I work on a weekly basis, is trying to identify communities where we're getting a lot of patient base in from, and going and talking to them just to see if, what the possibility of doing setting telemedicine up for their patients is.
And that challenge, is that more of a, we need to get visibility, or we need to, or are they coming to you saying, hey, we love this, but, what does it really take?
Both. Some of it is a patient has come in, and we have signage. I've got a monitor outside on the wall of our office that has telemedicine stuff going on all the time. And so we get calls from patients and say, okay, I saw your telemedicine monitor. Tell me how I can be seen over telemedicine so I don't have to drive 2 hours in to see my doctor. And so some of it's driven that way. Some of it is a hospital administrator has been at another hospital that has telemedicine, and they said, hey, we want to learn about that. Is that something that we can do? So, it's kind of a combination. Some of it is I work with the different departments to see, where are their patient loads coming from? Is there a certain area that they're getting a lot of patients in from? And if that's the case, maybe, I go and try to start talking to the communities and say, hey, a lot of your patients are coming into Lubbock. So let's talk about telemedicine and see if this is an opportunity to keep your patients here, as opposed to having them travel on the road to be seen.
Mm-hmm. Okay. So now, let's see. Knowing what you know now, is there anything you would have done differently in your experience?
I don't know that there is, because it's the challenges that have taught us what needs to be changed in the long run. So if we hadn't had those challenges, I don't know that we would be where we're at today. So, changing something, I don't know. I mean, I would change the state legislator and make reimbursement a lot sooner, but, other than things like that, I think that, the learning curve that we've learned from, that, the mistakes that we've made has really helped us know what we need to do in the future. And without making those mistakes, we wouldn't know what we need to do to go forward.
Right. Very cool. Good. Yeah, and it's always a learning experience. Sometimes there's just no way to make up for the mistakes, right? I mean,
Exactly.
if you learn
Exactly.
from them, that's the best thing you can do.
Exactly.
And yeah. All right. So what advice would you have for someone who's just starting out with their telemedicine program, whether it's an academic medical center or not?
Well,
Any do's and don'ts? Yeah.
I think one of the things, learn as much as you can about, um, the reimbursement in your state. Learn about what the medical board rules are in your state for doing telemedicine, and then talk to as many people as you can that are already providing the type of services that you want, whether it's mental health services or neurological services, those kind of things, to try to learn as much as you can and then build your plan from what you've learned from the others. There's a lot of resources out there. American Telemedicine Association is a great resource. There's a lot of telehealth resource centers throughout the U.S. that have good insight, and they're good people to be able to talk to gain that knowledge base to learn what you need to do. Um, the other thing is, don't, if you're looking at technology and the equipment, talk to as many vendors as you can, have them come out and do demos of their equipment and look at what all your options are, because there's a lot more vendors doing telemedicine now than there were even 10 years ago when we were trying to build our programs. And so there's a lot more opportunity at a lot less cost now than there were, when we first started. The biggest expense in telemedicine equipment is in the peripheral devices. And it's because up until recently, there just hasn't been very many vendors that were providing those type of equipment. And so now, because there's more and more vendors, it's becoming more competitive. And so there's a whole lot more options.
And you're talking about like the scopes and maybe even an
Yes,
ultrasound that you can attach and
exactly. And, we've been testing out iPods and or iPads and BlackBerry tablets and things like that to see what we can accomplish on a smaller scale. We are equipping a lot of our medical students with software technology and video cameras so that they can link back in through a laptop, to do classroom work, or as they're doing their rural rotations, they can use that technology to link back to talk to a professor, or, we're figuring out, can we use it to present patients if we have devices that we can attach to the laptop. So we're really, we're constantly looking at what new technology is out there that we can use that will make it more affordable in the long run.
that's great. And so you're able to think about how you could actually change one technology out for another later on as well,
Yes.
because then your physicians primarily would end up having to use potentially different technologies, one for one location and another for another one. Is that true
Yeah,
or no?
basically, with the tablets, if you have a physician that's getting ready to discharge a patient, um, with all of the continuum of care issues that we're trying to come up with, the readmittance avoidance, our concept that we're trying to develop and work on right now is equip that physician with a tablet, have him link back to the primary care provider of that patient so that they can discuss, okay, treatment plans once they get back to their community, what they need to do to keep them from being readmitted to the hospital. And so that can be done in the patient's room before they get discharged, linking back to their primary care provider so that they have that continuum of care coordinated so that that patient can be taken care of the best way possible. And so utilizing, the iPad or the BlackBerry tablet or things like that, it is a great opportunity to be able to do those kind of services.
That's cool. And so now, one last thing based on, you're a telemedicine director and you see all the great successes, you see some of the challenges of what you get to, what you deal with on a day-to-day basis. What would you say, well, two things. One, what excites you about the technologies and capabilities you see coming out, right? And I know you're working on the iPads and iPhones and everything. And two, what would you say to a telemedicine vendor saying, hey, you know what, I'd love it if you would come up with something like this?
Well, first, what excites me is that we can do so much with a lot less technology. Excuse me. We can use the iPad to be able to link and talk back and forth. Um, we can use the technology to link to other countries. We're not doing that right now, but we've got several countries right now that are talking to us to try to figure out if we can provide services to them. And I think that, the opportunity there is just huge. And it's not going to cost a lot because the technology has come down in price so much that we'll be able to do a lot more for a lot less. And so that's what excites me about, the technology. As far as something to recommend to vendors, they've got to look at, as we shrink the technology pieces, using laptops and using tablets and things like that, they've got to come up with devices that we can attach to the laptops, otoscopes, stethoscopes, general exam cameras, that are good quality that we can run through a laptop to make it more mobile. And so that would be my recommendation to them.
That's cool. Okay, very good. And okay, a last question for you. What's next for your program, and where do you see things going?
Well, we have applied to be a telehealth resource center. We applied for the grant. I'm still waiting on that. Right now, Texas and Louisiana doesn't have a resource center attached to us, and so we applied for that. I'm keeping my fingers crossed that that's going to occur. We get a lot of requests, not only statewide, but from other communities across the U.S. about trying to do telemedicine. We've been doing this since 1990, so in a lot of ways people look to us as, okay, you've been doing it for a long time, help us, let's learn from you. And so we're trying to take that and be able to expand that out through a resource center. So that's one of the things that we're hoping to get good news later this month about that. And then just we're trying to figure out more communities to go into. In Texas, there's a process, 1115 waivers, trying to figure out how to take care of the Medicaid patients that are out there, the indigent patients throughout the state. And so we're really working with some of the critical access hospitals out there on how they can get telemedicine set up. I would like to see in the state of Texas a nation, a statewide network where we're all linked in together. That has not been typically the case in the past. But I think if we're truly going to try to take care of patients, no matter where they're located at, we need to have everybody networked in together. So it doesn't matter whether the patient's seen in Lubbock, they're seen in Houston, they're seen in Dallas, that we're all working together to try to figure out how to take care of patients.
Cool. Very good. Yeah, and I wish you luck with the grant. I hope that comes through. You guys have done a tremendous job already, so it would make a lot of sense for you guys to be able to get that resource.
Well, I think so too. So that I'm staying positive, and I really think that the fact that Texas is so large and that we don't have one right now, that being able to have it and we brought Louisiana in with us with LSU. I think that the potential to be able to provide a lot of expanded opportunities to people through the Resource Center could have a real big impact on our two states.
Yeah, very good. Very cool. Yeah, Texas is so big. It's, going 350 miles from, you said Lubbock to El Paso?
Yes.
Right? That's like going from Richmond, Virginia, where I grew up, all the way up to New York City,
Oh, yeah. I was in Boston not long ago, and people were talking, oh, yeah, it took, I came from New York, and it took me an hour to get, hour and a half to get here. And I'm like, okay, I could not go across the state of Texas and that much. And you went through how many states?
Yeah.
So it's a big state, but we have lots of potential, and I think there's lots of people that are starting to understand that telemedicine can have a big impact on how we provide healthcare.
Absolutely. That's good. All right, cool. So, Debbie, this was absolutely wonderful. I appreciate all the insights. I know the people that listen to this interview are going to really get a lot out of it. So thank you so much for your time.
Thank you for the opportunity. I appreciate it.
Yeah, thanks. Okay, so and then hopefully we can have you back again sometime too. So
Love to talk to you anytime. I like talking about telemedicine. I have a passion for it.
yeah, I can tell. That's great. All right, thanks.